fatty food. We know in Jamaica that we eat a lot of jerk pork and all kind of fatty stuff. So a word to the wise is sufficient. But what is also without any question of a doubt is that if your father had prostate cancer, and worse, if your brother has prostate cancer, then you are at a greater risk to develop prostate cancer. The same thing applies to breast cancer. If your mother had it or your sister had it, then you are more likely. And it has to do with the genes which are passed on from one parent to a child. And in fact, the studies have gone further to show that those who have aggressive prostate cancer is directly related to your family history and your genes, rather than the food you eat. There are different types of prostate cancer, and I just want to turn your attention to two of them. One is treatable, and the other one is more aggressive. The cancer develops in your prostate in this fashion. And when it's detected in the early stage, if you look at the picture carefully, you will see very little of what you're seeing there now in the very early stage. As the cancer becomes more advanced, then you get the cancer appearing in both lobes of the prostate, because it has two lobes. And what you don't want to happen is for the cancer to be spreading outside of the prostate and going to other parts of your body when it becomes much more difficult to treat. One of the things that you should always get from your doctor when you do a prostate cancer test, whether it's the digital rectal examination or the PSA, and you're sent for something called a biopsy. And there's something called a Gleason score. And the Gleason score tells you primarily what your chances are, essentially. So that when you get the test done, you don't have to remember all of this. It's just to tell you what happens with the different Gleason scores. So that when you get your biopsy done, it usually comes back 3+3, or 3+4, or 4+4. The higher the Gleason score is, the more dangerous it is. If you have a Gleason score of 3+3, no matter what you do, and I'm going to talk about treatment in a while, your chance of survival are extremely high. In fact, I would dare to say, if you're going to get any cancer at all, and I hope you don't, then prostate cancer is the best one to get in terms of survival rates if you have a low Gleason score. And if it's detected early, which is the key thing while we are here talking about prostate cancer. Early detection is the key to everything. If you get a prostate cancer, if you get a biopsy and the Gleason score is 4+4, you are in some degree of trouble in terms of getting a cure, because those are the more aggressive cancers. And even if you get treatments, the likelihood that the cancer will come back. And there are different methods they can use now to treat recurrent cancer. So the Gleason score is important. And that's where your research should lead you in terms of questioning your doctor. When you get a diagnosis of prostate cancer based on the biopsy, you can only confirm prostate cancer based on the biopsy. To a certain extent, yes, the MRI can help you, not so much ultrasound. The examination can alert you that something is happening, but you can't tell somebody that prostate cancer based on the examination. you can just be cautious. And the PSA, unless it's extremely high, it's not a confirmatory test. It's a test that tells you need to go further. So the regular PSA should be below 4, that number in the lab. And for most people, when something goes wrong, it goes up to maybe 10 or 20. And then the biopsy will tell you whether it is cancer or not. If you get a PSA coming back at 200 and 300, then that's without a doubt cancer and cancer that shall spread. So again, we go back to the thing about early detection. If you wait until you have symptoms, it's too late. I want to repeat this. Let those who have ears to hear listen well. If you wait until you have symptoms, it's too late. And the symptoms are similar to what happens when your prostate is enlarged, but not cancerous. Well, some of them, not all of them. So if you start passing your urine often at nighttime, that's one sign. If you have difficulty passing your urine, what Jamaican people call stoppage of water, that's another sign. If you see blood in your urine, that's a possible sign. If you start to lose weight, that is a serious matter if you have prostate cancer. If you're feeling unwell and you have prostate cancer, that's a serious matter. And if you start to have severe pain in your back and elsewhere, that's also a serious matter. So when you go to the doctor and the doctor does an evaluation, and after all the tests, it comes back that you have prostate cancer. Whether it is the ultrasound or MRI or biopsy, what are the treatments which are available to you? Again, it depends on the Gleason score. So if your Gleason score is 3+3, and you don't have a family history of prostate cancer, but even if you do, in some countries, they will do something called watchful waiting. They leave you alone. And it depends on your age also. So if you're 80, because prostate cancer generally takes a long time to grow and to become troublesome. So if you're 80 or 70, in some countries, they will not do anything. They'll just watch you, repeat your biopsy in 6 months, do your blood tests, and see how you're progressing. In our culture in Jamaica, that's probably a potentially dangerous thing to do because we tend to have fairly aggressive cancers in Jamaica. So I wouldn't wait if I were you. Somebody's asked about what treatment would I recommend. I'm going to come to that in a minute. So we're talking about watchful waiting, which is one, very popular in Sweden. But they don't have a high incidence of prostate cancer in Sweden, so they can't do anything. So if you're going to get treatment, the doctor recommends one of 3 things initially. Well, one of 2 things, surgery or radiation. And radiation has 2 parts. One is what we call external beam radiation, and the other one is something called brachytherapy. And I'm going to talk about too much detail because it's not the forum for that. The other treatments only come in if you have recurrence or if the surgery and the radiation, they don't work. So you have hormonal treatments. You have something called surgical castration where they take out your testicles because it's your hormones which drive the cancer. And of course, finally, is chemotherapy. Can you prevent prostate cancer? Not really. I mean, there's some people who take something called saw palmetto for enlarged prostate, which is okay, but it's not going to stop you developing cancer. So basically, you just need to find a way to detect this thing very early so that you can get proper treatment. And the treatment has side effects, so it depends on the individual's age and status, whether below 60 or above 60, whether 40 or 80. A lot of it depends on your age and what is happening to you. And of course, your own personal decision as to what you'd prefer and what you'd not prefer. But at the end of the day, again, as your moderator said, the key thing in this is early detection, if you're going to have a chance. And trust me, prostate cancer is one of the best ones to have. Lots of people have been cured and live for a good old age. Even if they have prostate cancer at 60 and 70. Again, it depends on the Gleason score and whether it's aggressive or not. But if it's not aggressive, you have a very good chance of living for a long time, unlike some other cancers. I think I'll stop here, and if there are some questions, I'll try and answer them. If not, well, we'll see what happens.
All right, so for the question and answer, we could just go ahead, raise our hands. If you also want to write in the chat, you can. So this is, we're not the section, as Dr. said, that where we'll do some question and answers. I'm sure the men or their wives have some questions. So we'll take Paul Smith and then we'll go to Reverend Ivy. Go ahead, Paul.
Okay, good afternoon, everyone. Dr. Jones.
Yes, sir.
Couple of questions here. Large prostate. Enlarged prostate, does that mean a high possibility of having prostate cancer?
No. Many more people have enlarged prostate, what we call BPH. And most of them don't become cancerous. So there's no connection between an enlarged prostate by itself, which is very common. As you get older, prostate becomes enlarged anyhow. It's a natural thing as you age, it becomes bigger. But there's no connection between developing an enlarged prostate today and developing prostate cancer 4 years' time. No, there's no connection at all. It's just that you have to make sure at the beginning that it's just an enlarged prostate and there's no cancer in there. So whether the prostate is enlarged or not, we always do the PSA to make sure. And we always do the examination to check for ourselves that it's an enlarged prostate by itself. And what you're looking for essentially when you do the examination is to see if there's some nodules or if it's smooth. So if you find a prostate which is smooth and enlarged, that's a good sign. Once you find any kind of irregularity, and that's why the examination is so important, because in some cases, not often, you can detect cancer by what you feel, and the PSA is normal. So you can't depend on the PSA alone. You'll run into trouble. So the answer is no, there's no enlarged prostate and prostate cancer.
Okay, so the next question, just listening to your analysis so far, is that the possibility also exists that you can have elevated PSA result above 4 to 10, based on what you said earlier.
Or higher.
Yes.
We have seen people with 15 and 20 and there's not cancer.
So that's a question I'm asking based on what you was writing, what you were saying in your prelude.
Right. Yeah.
So it's possible for someone to have elevated PSA.
Yes.
Above 4.
And it's not cancer. That's true.
And I'm linking both now, and an enlarged prostate. But
yes,
your examination and other tests will say otherwise. That's what you're saying.
So that's where the clinical judgment of the doctor comes in now. So somebody comes at age 60 with an enlarged prostate and a normal PSA, or with a PSA like 6 or 7, what do you do? Well, because prostate cancer is so slow growing, what we normally do is repeat the PSA in 6 months. And if it is going down, that's a good sign. If it's going up, then that's when we probably send it to do a biopsy. And then the urologist should have to decide, based on several things, if you need to do a biopsy. Probably what is more important is how quickly the PSA is rising. That's why it's good to be seeing a doctor once a year. So if somebody comes 1 year with a PSA of 1, and next year it is 2, and the following year it is 4. That's a different matter for when it is 1.1 and 1.2 and 1.3. So the rate of increase is also important. If somebody comes 1 year with 1 and next year is 4, at that point you begin to wonder what is happening, because you can have prostate cancer with 4. So if it is rising rapidly, then that's where your judgment comes into to play, and you decide even at 4 you're going to send a person for consideration for a biopsy. Otherwise, you can miss some cases if it does hold fast to what Google tells you. And I'm being provocative.
All right. Next question. If one go ahead now and do a biopsy, and your biopsy is telling you that there is nothing evident,
There's no cancer?
Yeah, it is saying that there is no cancer. What how accurate that could be? How accurate could that be at that time?
Well, that's a good question. That's a good question. It's a very good question. You have to depend on urologist's skill, because what they do 12 to 15 single shots. That is, they put a needle in the prostate 12 times or sometimes up to 15 times. So you're dependent on that urologist to make sure that he's being as comprehensive in his testing as possible. So that's another thing about the judgment. You have to be careful who you send people to. You have to trust your specialist who you are sending that person to, that he's very capable. So that's a very good question. So if I send a patient to a urologist who I know and I trust, and you have worked together over the years, and they come back negative, in any case, we're always very cautious. So you don't just send patients away and say, okay, you're good. If the PSA continues to rise, they repeat the biopsy in 6 months or a year, just to make sure. Because you can miss things. What is also helpful nowadays, if you can afford it, is also the MRI. The MRI is not going to miss things, but the MRI is $45,000. Not everybody can afford that. And even then, you can't depend totally on MRI, because even with the MRI positive tests, the surgeons like to see things, to have tissue confirmation. So they will still do a biopsy even if the MRI is positive. And they may do it if the MRI is negative, if the PSA continues to rise. So you don't just depend on one modality. You be very careful about what you're doing. And you think through things very carefully.
Look for me, doctor.
Hello. That'd be nice. Lord have mercy.
All right. So the next question I want to ask you now, taking all the different precautionary measures, having done that, and your doctor is confident that, well, there's nothing present. Going forward, what you need to do is just keep check. Make sure that
so you repeat the PSA, and if there's rapid rise again or a significant rise, then you have no choice but to repeat the biopsy. Whether within 6 months or a year, depends on what is happening. And of course, it depends on the age of the patient also. So
okay,
for a young man, you be very careful. For an older person, you probably push back to a year or so.
Okay, that was, as I said, I'm taking notes. So in taking notes, I will ask questions based on what he said.
Okay, right.
Okay, Paul, thank you. You had a lot of questions. All right, we'll go to
that's a thinking man.
Yes.
Not
all right,
shy.
Bishop, you had your hand up, or we can go
Yes,
Yes,
Okay,
I
go ahead.
had my hand up. Good evening,
And
everyone.
then we'll go to
You
Bishop.
really want a bishop
evening.
you
Good
really want a
evening,
bishop
doctor.
to test me?
No, man. I was just wondering if you have presented all that you want to present before we start the question, so that
I think
you will-
essentially, yes. I mean, there are
All
lots
right.
of other things I could present, but sufficient. for
no
the day.
problem. So continue the question. I just want to show. So I would have asked that you maybe finish what you have, because you may not have plenty left, and then we do the question. So you're comfortable.
Well,
So
thanks, Bishop. Let me just share one more thing with you if I can find the picture. So let me show you two other pictures. 3. Okay. One of the things that they will do when they discover prostate cancer is to check all of your body whether or not there's any spread. So they're very comprehensive. So this is something called a bone scan, and you don't need to look at, but there's evidence of spread in this one, but that's not the point of this picture. The picture is just to assure you that in trying to decide what's the best treatment for you, your urologist will do a comprehensive test to make sure there is no spread in your body. Because if there's any spread outside of the prostate or through what we call a capsule, then that's a different treatment from when we're dealing with prostate, with the cancer in the prostate. So that's one point. This is a picture to show the cancer based on an MRI screening. So the MRI is also useful, but the expenses come into play. You don't need to know much about this picture. The only point I want to make here is that if you present late, if you don't go to your doctor early, and things go bad, and you need chemotherapy, this is where it gets very complicated. That's all I want to say to you about it. Just a very complicated slide. And there are a whole lot of different possibilities. And none of them work. They just delay the process of dying if you present too late. I'm going to tell you a story, a very instructive story, very short story, a very dramatic story. The wives can cut their ears when I'm telling the story. A man was brought by his wife one day, and right in front of him, she told me that she threatened him to withhold sex if he didn't come. He came very promptly. So I'm not saying this is what all wives should do. I'm just telling you what some wives will do to get their husband to come to the doctor. And she didn't tell me by whispering to me. She told me right in front of him. And he stood there and smiled. But he came, which was good. I'm sure the others will not come. So that's another story.
All right, go ahead, Dr. Mitchell. Bishop Michelle, sorry.
All right, good evening, everyone. Good evening to my doctor, Bishop, my doctor for the district, Dr. Ivy, and of course our presenter, Dr. Jones. Reverend Parkins, is good to see you as well. I am particularly interested in a root cause. I want to find out two things. It may sound like a rhetorical question, but for my sake, what, and you just caution us, I think twice or thrice, that we should not look to Google for, the source. So I'm happy that I have a doctor this evening. What is this cancer thing? It seems like this nebulous, hazy kind of disease. What is this cancer? And of course, there are different cancers, but in particular, what causes prostate cancer to begin with? That's one. Two, are there possible ways, preventative measures, to not have this kind of disease? My question.
All right, so one answer is general and the other one is specific. So cancer in general, only God knows how it started. What we do know is that cells which normally divide in an orderly fashion, for whatever reason, become unruly. It's as simple as that. They just begin to divide in very haphazard fashion. And what happens is that the division of those cells spreads so much that the original anatomy becomes distorted and it takes over the normal cells and chokes it off its blood supply. And that's why people die from cancer. It's as simple as that. It's a very complex thing. And there have been all sorts of research to try and target the cancer cells and why it started. We know in general, lots of reasons why people get cancer. If you smoke, and you smoke for too long, you will get cancer. Not everybody who gets lung cancer has smoked. I had a colleague who died recently, who died of lung cancer. He was not a smoker. But the majority of people who smoke will get cancer. If you have sex with many partners as a woman, and you develop repeatedly human papillomavirus, you stand a very high risk of developing cancer, especially if you start early in life and you persist in having multiple partners. That's why women get cervical cancer. It's caused by a virus. If you eat a lot of fats, as they do in North America, vis-a-vis what happens in Japan, you develop cancer of the stomach. Japanese men do not develop, for the most part, cancer of the stomach. And there are lots of other things we know that will cause you to have cancer. So in some respect, we have some idea. But in terms of the initial process, all we know is that cells become like popcorn, unruly, and stuff happens. In terms of prostate cancer, prevention, that's a hard one. You can't decide who your father is going to be. And therefore, if your father has prostate cancer, your risk of having prostate cancer is very high. It's as simple as that. If your brother has prostate cancer and your father has prostate cancer, the risk is even higher. So it comes from your genes, and you can't do anything about that. The theory that we're working with Jamaica in terms of fatty food is a live issue, and there's a lot of research going on. But so far, nobody has found a way to prevent Jamaicans from being one of the highest risk of having cancer in the world. It's extremely high in Jamaica, much higher than North America and in Europe and other places. So I know you're searching, and I know you said to, spoke about Google. My comment about Google, well, there wasn't that people shouldn't seek knowledge there. It's just that they shouldn't use Google to overrule, unless you have extremely good reason what your doctor says to you, which is a danger we are facing. A danger we are facing in Jamaica, and which was manifest during the corona epidemic, which, by the way, is not yet finished. Hope you're wearing a mask. I wear mine. And you can't come to my office without it. And I'm still trying to get people to get the vaccine. A third one and a fourth one. This corona is not going away. 400 people are dying already in America. But I digress.
Thank you, sir.
All right, so if anybody else have a question, you could go ahead. Just raise your hands or open your mic.
Hello, Miss Olive. I saw your daughter recently. Sure.
Hello, Doc.
All right, so probably the men get scared, Dr. Jones, by all the information that you have given.
No, it's
and
just scared. I just tell you what it is. There's
All right,
something
I could ask a question or two, Doc.
Okay, Bishop, go ahead.
All right, good. It has been a while I have listened to one like this, but you just mentioned for the lady cervical cancer, which has to do with multiple partner, you said is one of the main causes. Is it a similar thing on the men's side? Prostate cancer?
I wish I could tell them yes. No, but it's not true. I don't have an ammunition. I have to be truthful for that, Christian. No, but what is happening? I mean, there's not necessarily cancer, but you can get HIV, you can get syphilis and all kind of other terrible things, but not prostate cancer, no.
What about, is there such thing as too much sex?
Huh?
Is there anything as such thing for the men as too much sex?
Bishop, you can't into politics now.
No, I think sometime back somebody tied prostate cancer to sexual activities.
No, sir. Nothing like that, sir.
I'm not very clear as to when or long, but I think somewhere around here, so a link like that was made. That's why I'm asking you about it.
The good God gave sex as a gift to married people. Let me be very clear. That will follow up his laws and precepts. And I don't see the good Lord giving us something which is going to cause it to develop any kind of cancer. No, there's no research, there's no support of that. In fact, what we say to men who have prostatitis is to encourage them to, just in terms of, well, not get into that now, but encourage them to have sex more often, yes. And then of course, the caveat is that as a Christian, if you're married, you don't really want to give license to people to do stuff when they are being unruly. But no.
Man and woman.
This Hoover asked is asking a kind of political question, you know, it's a different forum for that. Yeah, let me not go there.
All right. Those who want the question, you can raise your hand. We will see it quickly and acknowledge you to ask that the question. Others who may not be sure about how to raise your hand, you see a reaction button on your computer. Just press there, you see the sign to raise your hand. You may be on your phone, a similar thing can happen there. But if you open your mic and we hear you want to ask a question, we still accept. Paul Smith, hand is up again.
Okay. I've heard, similar to Dr. Pastor Ivy, Bishop Ivy, question that men involved in sexual activity and had contracted those venereal diseases and so forth, that could be a possible contributor to prostate cancer. Is that so?
No, there's no evidence about that. And if that were the case, you can imagine the amount of prostate cancer we have in Jamaica. Our men are like stallions. Their mind is constantly on sex. Most of the young men. So let me not burn the problem because I could tell the stories, but the answer is no.
Okay.
What they need to start doing is having sex with one partner rather than having so many different partners. But that's a wider conversation.
Okay.
Brother Enzi, hand is up.
Good night.
Go ahead, Paul. Go ahead, Paul, if you're not finished.
Oh.
Go ahead, Paul, if you're not finished.
Okay, this is gonna be my final contribution. I am gonna be recommending to our men, once you can afford it, that you get your test done. And when you do your test, if you need follow-up and you can afford it, do it in its entirety, MRI, the what do you call the other one there again?
PSA,
No, you'd have to pass
ultrasound,
yes, your
ultrasound,
no, the one with them use a needle and stuff.
or the biopsy.
The biopsy, you go and get all of those done once you can afford it. It's very important, very important. And also, if you can afford it, men, I would suggest there is, not for prostate now, but the colon cancer. If you can afford your colonoscopy, please go and do it early. But if you start getting signs at that one, then you're in trouble.
That's a good
That's
point.
just my final contribution to this evening. Thanks.
Ms. Oliver, has a hand up? Or somebody before?
So we have Ainsley, then
Ainsley,
Olive. We have Ainsley.
Yes, sir. Yes, doc. How effective is the other test? I hear there are 2 tests. I don't know if there are more tests. The anal one I've experienced. But how effective is the other test? When it takes some blood or something?
That's the PSA, that's the blood test.
How effective is it?
Very. So as we
Okay.
were talking earlier,
Okay.
the first point that you combine both of them for maximum efficiency, you don't just do one. Both contribute to making a diagnosis.
Yes.
If the PSA is very high, then without a doubt you have a diagnosis. If the PSA is 200, and we have seen people with PSA of thousands. So if the PSA is very high, and go back to what I said earlier, if the PSA is rising rapidly, then those are indications that you need a biopsy. So it's a pointer to say that you should get a biopsy, because ultimately the diagnosis is made by getting tissue and sending it to the lab, and they make a.
Yes. Why I'm asking is that I know that the testing through the anus is a direct way of knowing, but what if human error occurs when you're doing the PSA test?
You mean at the lab?
Because it is done by human. Yes.
But the margin of error, the margin for error at the lab is very, very minimal. They talk about machines nowadays and technology and automation.
Okay.
So unless you mix up your sample with somebody else, which can happen, but that's rare. It's a fairly reliable test. They are moving on from PSA. There are other tests they are doing now too, but I don't want to complicate the matter. But medicine is always evolving, so there are other tests that they're doing to try and become more accurate, or as accurate as possible. But the general message really is that you don't really want to wait until these tests become positive. You want to at least become too high, so it's too late. You want to get them when it's very early.
Thank you.
Thank you.
Go ahead, Sister
Yes,
First.
Doc. I just wanted to say that the Cancer Society offers cheaper than what Mr. Smith was saying. That is not always very expensive.
Right, that's true.
Food is expensive, so we can find a way to do our tests if it's necessary.
Yeah, for both men and women, blood tests and mammograms and pap smears and stuff, yes. The Cancer Society does a good job. And it's all in the context of early detection for men and women, So the same thing applies for women and mammograms and checking your breast yourself, examination. For women to do their pap smears. And of course, if you can afford it, they're recommending more and more the colonoscopies for early detection.
Go ahead, Sister Lona.
Good evening, Dr. Jones.
Good evening, Sister Lorna.
How are you?
I'm well, Sister Lorna.
Alona.
Oh, it's Alona. Oh, it's you. Okay. I'm Sister Lorna.
Yes, sir.
Yeah.
Yes, sir. I just want to mention about the digital examination, and you said that many men seem to avoid it, and I think it's because of the homophobia in our country. So I think most persons are comfortable with asking a female doctor to do it. So if that is
Yes
a
and
drawback
no.
for the men.
Yes and no. It's not, well, the homophobia is part of it too. But it is painful because you have a, let me not digress too much. You have a sphincter, which is very tight in the rectum. You don't have a similar sphincter for women when they are being examined. And I could digress and get into all kind of politics here, but it is painful. So, and you can't deny that, it's painful. So whether it's a woman's finger or a man's finger, it's still painful. But the key thing is that it doesn't last long. 1, 2, 3, 4, 5, 6, and you're done. Can save a life.
Right, right.
So your point you're making is
I've heard
true, yes. They'll prefer a woman's finger than a gentleman's finger, but it's not going to last long either way. But the point you're making is true.
And I've also heard some, yes, sir. I've also heard some males saying that this female finger might be also smaller than the male's finger, so it might be a little bit more comfortable for them. I'm just putting it out there, because that's what I've heard.
I can relate to that. Yeah, that's an issue. But of course, you know that
So basically what I'm saying, that
more and more women are graduating as doctors from med school now, so it becomes much more easier for them. In fact,
right, for those males who might have an issue.
Right, yeah. Because when I leave my office on holidays, there are two.
Right, so
there are two women who work for me, so they can come at that time if they want to.
Go ahead. Right, because I just want to encourage them to get that examination. It seems to be very, very important. Right, so if the drawback is a male, then of course there's an option to ask a female doctor to do it for them.
Yeah, man. So I go on holiday.
All right, another question.
In July, so they can come in July. You have choice. You have two women.
Okay, sir.
And they're both very good.
Yes. The other thing that I wanted to ask is in relationship to the post-treatment. You mentioned that the cancer can be treated and they can live without it, without the cancer, and of course live for very long after the treatment, right? After the cancer has developed and it's treated. So my question was, if it can be post-treated, can it not be pre-treated? Because if you can live without the cancer after medication, but I don't know how it's treated, whether or not the person will have to be on medication for a long time. Is that it?
All right, so let's start again. So you have prostate cancer, you go to the doctor, it's confirmed, you decide what you want based on the recommendation and based on your disease score and all the tests that you have done. So for example, if you do radical prostatectomy, take out the whole prostate and some things around it, and you're looking for your PSA to come back down to 0.01 or 0.02. As long as it remains there, and we always encourage people to keep on doing their PSA after the surgery. You don't just do the surgery and tell people to go home and that's it. So you're constantly doing your PSA. So if the PSA starts to rise, then you know that there's trouble, because that means that either you did not get the entire thing out, or there was some spread somewhere which you did not detect. And depends on whether or not it's an aggressive cancer or not. If it's a mild cancer, 3+3, you can get hormonal treatment, which will keep the prostate quiet for a very long time. The key thing in this is aggressiveness of the cancer. If the cancer is aggressive and comes back, there's not much you can do, essentially. You're going to die whether it's 2 years or 3 years or 4 years. If the cancer is not aggressive, then you can live a long time on hormonal treatment, getting injections every 6 months or so, or every 3 months, as the case may be.
Okay.
So there's constant evaluation
Okay,
and
so
there's constant follow-up. We don't leave people alone because we have done the surgery or the radiation.
Okay.
You're forever.
Because
you're
I
forever,
was thinking that if it.
Yeah.
Go ahead. Go ahead, sir.
No, I'm saying you're forever in the
You
care
were
of the
saying you're
doctor.
forever?
You're forever in the care of the doctor once you have cancer.
Oh, okay.
Because they have to monitor you all the time. So we talk about recovering from cancer. We don't talk about cancer-free and you've been cured of cancer. Always recovering from cancer.
Oh, okay. That is what I wanted to find out, because I was going back to the preventative measures that you said that is a bit tricky. But now that you have explained that persons might have to take out that particular part, and that is what could cause them to live without the cancer, then it kind of explains to me what is really happening and why they can live without
most people who have cancer of the prostate, mild disease, low bleeding score, you take out the cancer, there's no spread, they will live and they have something else. Not the cancer. They're there for stroke or.
Okay, and does it cause? Oh. Does it cause erectile dysfunction?
You mean the cancer?
Removal of?
Yes, that's a big problem. Yeah, that's a big problem with prostate cancer surgery. So there are two big issues. One is urinary incontinence, you can't control the urine. And the other one is erectile dysfunction. To a certain extent, the erectile dysfunction may come back, may become normal, can be treated in some cases. The incontinence is trickier. That's more difficult to treat.
Oh.
Because you're moving tissues that help you to control your urine. And if it happens to you, and depends on the skill of the surgeon, it depends on how much work he has to do and stuff. So because the technology is always evolving, so you have robotic surgery now, which reduces the possibility of both of those two things. And that's why some people opt for radiation, which gives you less of a challenge with erectile dysfunction. It does not remove the incontinence. And the brachytherapy, which is a more advanced radiation, the risk of both of those are significantly reduced. So there are options already.
Okay. And then, of course, many persons are worried about the expense. So if the health insurance would cover how much or how helpful is the health insurance?
It depends on what coverage you have. So if you have good coverage, it probably will cover maybe 2/3 of the surgery. Prostate cancer surgery is expensive. But of course, the option is to go to a clinic, hospital. The problem there is the waiting period, always. So you have two options. Either you go to a private doctor or you go to the clinic. Going to a clinic is a bad idea, but sometimes that's the only thing that people have, only recourse they have, because it takes so long to get treatment. The same thing with breast cancer. Yeah, we have seen some disaster stories. So I try to get my patients as much as it's possible to get treatment as quickly as possible. But going to the hospital, it doesn't always work out. And that's a challenge for the health system in Jamaica, which is a major issue.
Okay, sir. Thank you very much.
Thanks. One more question. I have to run. You're done?
Not sure who will get that $1 million question. Paul is on again.
So Paul, open his mic. Oh, go ahead.
Paul is on again.
Okay, I've just listened to you and your different treatment and all of that. I've known persons who have had surgery, and there's this this urinary bag that is used as which one of the surgical cause that has to be done. Which
Well,
one of the treat-
you're talking
which
about
one of the treat- which one of the treatment in the
You're talking
prostate
about
process?
a catheter, which is what you see here. So once you're going to do surgery as an option, they're going to put in a catheter and they could take it out after about maybe a week, 2 weeks, sometimes 3 weeks, depends. But they take it out after a while and then you're good. But most commonly we use the catheter to relieve obstruction in people who have enlarged prostate and not necessarily prostate cancer. So this is a procedure which we use all the time with men who come in and they can't pass the urine. They put in a catheter and then the other things we'll have to follow after that. How long will it keep, what they need to do, etc. So they put in a catheter most times for any kind of surgery, just to monitor the urine and make sure that you can pass the urine. So not only for cancer surgery. So this is in the male where it goes to. And address what you're talking about.
No, I've known persons who have lived a long time and they still have it in.
Yeah, that's a crying shame. That's part of the problem with the system. They have enlarged prostate and they can't get the surgery or some other thing.
Probably the real question I should ask, what will cause someone to be permanently having in this catheter? Probably that's
so the permanent retention of a catheter ought not to happen unless something really has gone bad. But because of the system where people can't get treatment quickly, men have to be wearing a catheter going on, which is an absolute disgrace. But it's a major issue. Most people should not have a catheter permanently.
Okay.
Okay.
That's your question. That's it for you, Crit, Paul?
Yes, that's it. That's it.
As we say in Anglican Church, the Lord be with you. And you're supposed to say, and with you also.
And with you also.
And also with you.
And also with you, yes. And also with you.
Also with you. All right.
Yeah,
we want to look for our emoji buttons and look for our heart, a clap and a thumbs up. And at this time, we will just hit on one of them for Dr. Jones' presentation. Doc, if you could stop sharing your screen so we could see the those popping up. Thank you so much. Before you go, Doc, we know you have to run. We really want to say thank you. So at this time, I'm going to ask Sister Cheryl to move a vote of thanks to Dr. Jones.
Mr. Who?
Hi, pleasant evening.
Go ahead, Sister
to
Cheryl.
my brothers and sisters and visiting friends on this platform, and to my handsome doctor.
Oh Lord, have mercy.
So it gives me great pleasure to move this vote of thanks on behalf of the Mineralized Family Life Ministry and also the Men's Fellowship Department. I extend heartfelt gratitude to our esteemed guest speaker, Dr. Lucien Jones for accepting the invitation to enlighten our men about prostate cancer and to arm them with enough information that can help them to fight against this feared disease. We could not have had a more enriching, interactive session, and I am confident that our males are more empowered to fight. Thank you, sir, for availing yourself to be used in this manner. And may the Lord continue to enlarge your territory and pour out his richest blessings in your life as you continue to extend yourself to serve in the various capacities in this nation. Once again, thank you, sir.
Thank you very much. And please tell your wonderful daughter hi for me and your dear husband.
I will, sir. Okay, thank you.
Once again, we hit our